Tonight. So I'm Dr. John Martin. I'm the Chief Medical Officer of Butterfly, and I want to welcome all of you to the POCUS Power Hour. This is a monthly program that we put on where we cover very important topics in point-of-care ultrasound, and we bring together some of the most gifted experts in not only point-of-care ultrasound, but physicians themselves. And I will say tonight is no exception. In fact, this is what I would like to call an E.F. Hutton program. For those of you that are old enough to remember that commercial, these two physicians, or when they speak, people listen. So we're very fortunate tonight to have these two experts to address a topic which I think is sorely needed and will have a huge impact on care across the country if people actually heed the words that these two will share with us tonight and actually adopt POCUS in the triage area of our emergency room. So Peter, I'll turn it over to you, my co-host, Peter Weimersheimer, to introduce our guests.
Thanks, John. Thanks for the great intro. Peter Weimersheimer. I'm an emergency physician, and I'm the VP of Education and Clinical Implementation at Butterfly. And yes, really looking forward to a great webinar. We have two just outstanding guests, and including, for me, a friend, two friends. And so that's Dr. Courtney Smalley from the Cleveland Clinic and Dr. Resa Lewis, who I'm going to say from Brown and from the world in terms of all the things you're doing. So love to have you introduce yourselves and share your wisdom.
So great. Good evening, everybody. My name's Dr. Resa Lewis, and I'm going to share my screen and get going with some slides. There we go. So it's wonderful to be here with, it looks like almost 40 of you. And please, 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 in the chat box, feel free to start putting in questions and comments because this will be an interactive session at the end. The way we've outlined the hour with you is Courtney and I are going to speak, share a little bit about our innovation and what we think. And we think that what we think is going on in our shops is what's going on in your shops. And so we know this will resonate. As means of background, I am an adjunct professor of emergency medicine. I have an appointment at the University of Alabama, Birmingham, and as of June 1, an appointment at Brown University, Warren Alpert School. I'm a co-founder of Sono Games, which is now 11 years old. I'm the past president of the Academy of Emergency Ultrasound of SAM. I served as president of SCUF. I served as president of the chair of the ASAP ultrasound section. So every emergency medicine organization, ultrasound at a national level, I've played a role with many, many, many others. I was a signing member of the charter in Milan, Italy of WinFocus as a founding member, and I served on the board of Pure Ultrasound, which specifically did work, train the trainer work in Rwanda, Uganda, and other parts of the world. I'll just share one more that people may wonder, what is the origin story of Resa and Courtney? I worked for 12 years in New York City and was recruited to the University of Colorado. And when I started as ultrasound section under emergency medicine, Courtney had been recruited as an early career faculty member after completing fellowship. And we hit the ground running together as innovators. We built a lot of innovative programming. We published a lot of integrative work. And you will be hearing more about that innovative and integrative work. Baton to Courtney.
Thanks, Resa. Thanks, everybody. I'm so excited to be here. My name is Courtney Smalley, and as Resa said, we started our journey together about 13 years ago now. I am currently an associate professor of emergency medicine at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University, and I have held the position of director of emergency ultrasound in the Cleveland Clinic Health System through our emergency departments for the last 10 years, and I'm currently serving as the vice chair of education. I am so pleased that we have been invited to talk about this really important topic because we work a lot clinically and we believe really wholeheartedly in what we're about to discuss with you. We hope you guys bring some great questions to the table and pick our brains and push us further. So I'll turn it back to Resa.
Thank you. So I want to make sure we're all starting from the same framework. POCUS is a data point. Now, you may be like, what is she talking about? But bear with me, bear with us, you'll get it. We as emergency physicians, we do the history, we do the physical, We do a POCUS examination for almost all chief complaints. We could probably do a POCUS. And that leads us to decreasing the time to definitive time and management. History, physical, POCUS, decrease the time to definitive diagnosis and management. Now, to be clear, that idea came from an amazing online lecture that I saw on the FAST examination authored by Dr. Jalen Avila. So Jalen, hat tip for really highlighting this aspect of POCUS as a data point. I'm going to walk you a little bit through the evolution of point-of-care ultrasound. These icons, and you can tell I like icons, will basically walk us through this history of this evolution up to what we're talking about today, which is POCUS and triage. So in the 1990s, the FAST exam, the focused abdominal sonography and trauma, the A stood for abdomen, because it really landed in this country coming from Europe and Asia via trauma surgery. The trauma surgeons had heard about using ultrasound at the bedside to evaluate blunt trauma patients, and they were specifically replacing, at this time, the diagnostic peritoneal lavage with the use of ultrasound at the bedside. Is there fluid? Yes, no. So we know that emergency medicine sort of took the baton from trauma surgery, and we extended that blunt trauma exam above the diaphragm, so it became thoraco-abdominal trauma. And we also know it wasn't just blunt trauma. We started looking at it for penetrating trauma and for some non-trauma applications. For example, the FASH exam, the focused assessment of sonography in HIV-associated TB. This application was very much driven by our global health colleagues and specifically by infectious disease. So by this point, we had moved from the 90s to the 2000s, well into the 2010s. Now, late 2010s, as we started entering COVID, many of us were dealing with some of the same challenges in the emergency department. Many of us began doing triage shifts. And as ultrasound trained emergency physicians, we know that POCUS provides a data point. So when I was preparing for an innovation summit at the invitation of Butterfly a few months earlier this year, I was actually speaking with Courtney and saying, I really want to talk about something innovative, something that hasn't been talked about yet. And we started playing with this, the evolution of ultrasound. Where is it going next? Where has it gone next? And we started speaking about triage and triage shifts and how all of us want to be able to provide safe patient care. And how much better do we feel when that safer patient care involves a point-of-care ultrasound unit? So here are these evolutions: the focused abdominal sonography and trauma, the focused assessment with sonography and trauma, focused assessment with sonography and HIV-associated TB, and finally the focused assessment of sonography and triage. Baton to Courtney.
So moving into this triage model, I think it's really important, and we all live in this world where we know that emergency medicine is getting harder. This first graphic is demonstrative of what we're dealing with ED crowding and boarding right now. So many emergency departments are busting at the seams. There's patients in the waiting room, patients waiting to go upstairs. Our biggest fear as emergency physicians and emergency providers is somebody dying in the waiting room. I think about this every day. I always think, who is in the waiting room? Who's sick in the waiting room? Who needs to come back? Who are we missing? It's our biggest fear. From the patient perspective, these patients are sitting in chairs out in our waiting rooms, watching the clock and waiting for time to come back, not knowing if it's going to be 1 hour, 3 hours, 6 hours, depending on our volumes and the boarding and the crowding that's going on. And we all know that our patients are getting sicker and sicker. I feel every day in my practice of emergency medicine that the patients that are coming in are sicker patients than what I saw 10 or 15 years ago. And then last, we're looking for these data points in triage. We're trying to figure out which patients need a rule-in diagnosis. How do we find those patients that may not present with the abnormal vital sign, the obvious need to go back to a room? So this is where I started thinking about ultrasound in triage. And I'm going to give you an example of a couple of cases that Resa and I started discussing when we were talking about innovations for ultrasound in triage. I started reminiscing about some of the patients that I was seeing in my physician and triage model. So the first case I'm going to talk to you about was a young man that came through the door. There were many patients in the waiting room. I always find that it's so interesting that, patients seem to all arrive in groups of 10. And the line was 10 deep and 10 people signed in under 10 minutes. And this young man came back, Spanish speaking. We got his vital signs. The nurse asked him a couple of questions and he said, I just feel I feel short of breath. I was working, all of a sudden he's a young guy, 20 something years old. I feel short of breath. Something in my gut when I started talking to him made me think, gosh, I could take an ultrasound out of my pocket right now and put it on his chest and quickly look at his lungs. The nurse was like, just order the chest x-ray, get the diagnostic, order the labs, let's keep moving. It took me less than a minute to put an ultrasound on his lungs and find that the patient had dropped a lung and had a pneumothorax. So here we were, a patient with relatively normal vital signs that probably would have gotten sent back to the waiting room, and we ruled in a potential diagnosis. I sent him right back, confirmed it with the team in the back, and he got a chest tube. Another case I had was an elderly gentleman in his 70s, really hadn't sought medical care. Coming in with shortness of breath, the typical complaint, such a hodgepodge. You can put so many things into shortness of breath. I looked at him quickly. We got some vital signs, a little tachycardic, but otherwise looked well. Just kind of looking over him head to toe, I kind of noticed he had maybe a little bit of fluid on his legs. I asked him if he had any history of heart failure or problems with his heart. He said no, but he had not sought medical care in years. I took an ultrasound, put it onto his chest, and looked at his ejection fraction, just looking at the squeeze of his heart, not making any major diagnostic decisions, but really just to see, what does this guy's heart look like? And sure enough, I estimated that he had an ejection fraction of almost certainly less than 25%. I got him back to a room. They called cardiology. His care was expedited, and he was admitted to the cardiology service in under a couple of hours. The third patient I'm going to tell you about is one of my favorites because I think this is one that could have easily gotten glossed over. It was a middle-aged woman, very morbidly obese, came in a wheelchair. I think because of her obesity, maybe didn't walk well at baseline, saying that she was having urinary complaints, groin complaints. The nurse brought me in after she got the triage vital signs and we got the initial labs, ordered everything. I walked in to ask her a couple of questions and she just looked too uncomfortable. The nurse was like, let's get her back to the waiting room. She probably has a urinary tract infection, pyelonephritis. But something just kind of said, let's take a quick peek. She was wearing a skirt. I asked her to lift her skirt and I could see a rash. I took my bedside ultrasound, which I brought out to triage that day, and put it on her and I saw gas. I immediately got her back and she was in the operating room within 2 hours for neck fash. My last case, another example was, and this one is one that I think we've all diagnosed with point of care ultrasound if you work in emergency departments, a young female, last menstrual period 8 weeks ago, coming in, having some belly pain, sudden onset. This one was a quick one for me, but I think people don't think about doing this study in triage because again, we're looking for the rule in. She was sitting in a chair. I just asked her to kind of move down in the chair a little bit so I could put a probe down near her pelvis. Again, looking for a yes/no answer. And ultimately, I didn't see an intrauterine pregnancy and I saw some free fluid. And that immediately triaged her right to a back bed where she was diagnosed with a ruptured ectopic. So I bring these cases up because I think people think about ultrasound and triage and we think about time and efficiency. But I really want to stress to the audience that we can do this and it is efficient. And we always wonder, like, is there time? Do we ever have time? But these 4 cases took me less than a minute, maybe 2 minutes to perform in the triage room quickly without any additional resources. The second thing I want to stress is that we do this. We are already masters at the ultrasound, and all of the equipment, the workflow, the education is built into our emergency departments. We are the forward-thinking group in medicine. I think we bring such diagnostic capabilities to the table, and these workflows are already in place. So if you're going to bring your ultrasound to triage, you likely don't need to add anything to your existing workflow capabilities. I love this. And Resa and I remember we were talking about this, and Resa said, as we were kind of just chatting and about the future, she said, if we can undress a patient in triage for chest pain and put a bunch of sticky stickers on them and leads, why can't we take an ultrasound in there? And I thought that was just the best example of what we are capable of with an ultrasound. And then last, we all work in hospitals where there are administrators and hospital leaders that could say, hey, you know, is this something that's really worth it? Well, the bottom line is we already are billing for these studies. We are doing, we support our programs. These have CPT codes, which are billable codes. We are providing diagnostic care for our patients by doing this in the waiting room.
So what I'll say is I agree with everything that Courtney has shared. And just part of what we've provided in that last slide is all the reasons why there should be POCUS and triage. But as she shared, we know the business of emergency medicine. We have gotten the pushback. We know that people are going to say it's more time. We don't have room for the machine. What about the workflow? And so those were all reasons to support you implementing this today, tomorrow in your emergency departments. And I have personally been met on many occasions with the business case, the business case, the business case. And so to be clear, we are not advocating for the phantom scan. We're not saying quick look, don't, we want you, save your images, write a note with your triage note, because those images and that note can then be read by the consultant, can then be read by your colleagues who are working inside the main ED and want to know what you found. That's going to help them with a consultation, with the next diagnostic study, etc. So no talk would be complete without offering our appreciation and thanks. Thank you to all the Butterfly team members. There are many people of the POCUS community whom we could name, and I just wanted to call out Jalen because she really, really put this concept of POCUS as a data point that should be a part of our workup, and it helps us provide safer, better care. So with that, I'm going to stop my screen share, and we'll send the baton back to Dr. Peter Weimersheimer.
Thank you both. I have to say that this is something which is almost astounding that this doesn't happen. You know, that in emergency medicine, we understand the pressure of time. We understand that heartache of someone who in the waiting room who leaves or who doesn't get seen and has something catastrophic. And you know, there have been so many different solutions where providers who don't scan will go out and try and do a quick triage, or will try and have people bring people into some sort of place that they can get scanned. So I guess the question always for me remains how to the barriers to this not happening by this point in time, and especially where ultrasound is so prevalent and such is part of their core curriculum, and solutions to try and have it become more prevalent.
So what I'll say is Courtney and I recently wrote up a piece, like a perspective piece, making this argument, which I think everybody on the call probably knows, there's no argument. We should just be doing it. I think it's actually, we just are siloed. We know ultrasound is in the main emergency department. We know ultrasound is in the resuscitation room. I think hopefully some of you just didn't think of it. And hopefully now attending the power hour, you'll go into your next shift and be like, oh my gosh, of course. I can roll something in. I can have a handheld. I can fill in the blanks. We encourage, like for all processes in the emergency department, like work with your medical director, work with your operations, work with your biomed, work with your information technology. Make sure you can use that workflow. But there's no reason not to if you have a point of care ultrasound program in your emergency department now.
Yeah, I'll just echo that. I think the barrier is just the idea that you can't get the ultrasound out there. And until we started doing physician and triage shifts at the Cleveland Clinic, I don't think we would have been implementing ultrasound and triage. because the triage protocols were nurse-driven protocols. And when we put physicians in triage about 18 months ago, even myself as an ultrasound expert and an ultrasound advocate to all of our community, didn't really even start thinking about bringing it into triage for the first couple of months. I was so inundated with the stress of being in triage and seeing all these patients in a short period of time, trying to catch that, elusive diagnosis. Who should go back next? How do I order them? And within a couple of months, I kind of woke up one day and showed up on a triage shift, and I said, why don't I have my ultrasound with me? I always have an ultrasound. Why don't I have my ultrasound with me? And I went back to the area of the main emergency department, and I took one of our machines and I said, I'm bringing this to triage. And our nursing team looked at me and said, Dr. Smalley, what are you doing? And I said, I'm going to do ultrasound and triage. I'm going to make some diagnoses out here. I'm going to figure out what people have and what they don't have. And we're going to triage them and get the people back that need to get back. I'm going to start calling consultants. I'm going to provide better care. I'm going to get the right diagnostic test. I'm going to order the right CAT scan, the right chest x-ray, because I'm going to use my ultrasound to help make that plan of care, to make that data point in the patient's chart. And I did that, and I started putting those images in the system. I think Resa makes a really good point. I immediately ordered the study as I was walking into the triage room, did the study, the images pushed directly to our PACS. I could call cardiology from the waiting room. I could call ophthalmology for retinal detachments. All of a sudden, I was feeling very productive and feeling like I was making a difference for those patients in the waiting room. And so I don't think it's a matter of the barriers, is just a matter of when, and almost just getting the message out there that people can do this. You already are doing it. We are the masters of space and practicing emergency medicine in any austere environment. I always joke that the waiting room is that austere environment, and that's the next area that we need to tackle. And as we redesign triage workflows, we should be implementing data point, ultrasound as a data point in our practice.
You're on
I'm
mute, John.
always fascinated. Yeah, the dogs were barking. I had to do dog protection. I'm always fascinated with how things go in healthcare. And essentially, you can look at Jalen, for example. There's a period of time where it's an innovation. And you can say, oh, this is this exciting new thing people are trying, but it's looked as a kind of out there thing. It's an innovation. Then all of a sudden it becomes, well, it's a best practice. Those people that are actually practicing at their very best, they do that, but not everybody. And that final transition is where it becomes the standard of care.
Mhm.
And that's where if you're not doing it, you've got the L on, you're a loser and you're practicing bad medicine. And I guess my question to both of you is, where are we, if you will, in that scale? And how do, as you guys as leaders at the premier institutions in the country, sitting at that level of national organizations, how do we move this? Because listen, let's be candid with each other. There's no way you could look at this and say it's not better medicine. There just isn't. I'm sorry, but there's no one who could come at me with an argument that says this isn't a better way to practice care. And if candidly you've ever been sick in an emergency room and waiting, knowing I practically the last time wanted to pull out my own ultrasound and show them my own pictures, but it's clearly it's better. How do we move down that pathway? And how do you guys use your roles as national experts to accelerate this to be in today's modern emergency room, whether it's in an academic center or otherwise? You guys have trained to have these skills. This has to be part of the way you take care of patients.
Do you want to take it first, Courtney?
Sure. So I think you are hitting the nail on the head. And I think that's what in the last 4 months, have been thinking about. How do I bring this so that everybody is putting an ultrasound in their hand? And what does that look like? What do I need to provide to the doctors and the staff up front to make them feel comfortable throwing an ultrasound out there? I think ultimately, where I envision this going is that triage, and well, what I'm hoping to build within our sites is that the triage protocols include opportunities for point of care. So we think of these nursing-driven protocols in triage that have been around for ages. A patient comes in, they're a diabetic, they get a finger stick glucose. They've got chest pain, they get an EKG. I'm envisioning, and as I kind of innovate about the patient complaints we see, how do we look at triage protocols and integrate the ultrasound into that data point during triage? And I think it once we introduce the the protocol as this is a part of what we should be doing, then people will, the physicians who have been doing it for years and are already doing it at the back, I think they won't think twice because they'll say, oh, patient has chest pain, they get an EKG. A patient has this complaint, they get an ultrasound. And I'm hoping that we can, as a group, as a national group that is experts in this area, really push that needle forward to say, what are these chief complaints and what can we use an ultrasound to do? 2 points. Number one, those cases I described, some of them were a rule-in diagnosis. I was looking for a critical diagnosis. Some of them are just to make a diagnosis, right? And the example, I didn't give this example, but we see a lot of eye patients come through the emergency department, and I make the diagnosis of retinal detachment, vitreous hemorrhage very frequently from the waiting room. And many times those patients don't even need to make it back to a true bed before the ophthalmologist has been called. So why aren't we able to just build a vision protocol where ultrasound is a part of it? And so those are the types of things that I, envision that we can move the needle forward. Risa?
Yeah, so I love what you just shared. And to me, that falls under the umbrella of automating. Just make it automatically a part of the process. And I think your example of chest pain, everybody gets an EKG, diabetic, everybody gets a finger stick, you know, just automate it so people don't have to think. I think we all are used to the cognitive overload of working in the emergency department. So if we somehow just work it in as part of the system, I've learned over my 25 years is one of the ways you move things forward is publish, 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 publish. There is this currency of getting it in writing. If people have a policy, if people have a perspective piece, if people have a prospective convenience sample study, then they can bring that to their supervisors, to their leads, to the resistance. And, I have built and led ultrasound sections within departments of emergency medicine at 3 major hospital systems. And the resistance can be real, and you become a bit of an outlier if you are the one doing the ultrasound. And so it means doing what you think is right for the patient. But I think once you show the wins, the saves, the successes, that can be compelling. So I think demonstrating those to the department, automating it. The reason I brought up the business model and the return on investment is some systems, many systems, are very, very, very focused on the bottom line. And they want to see that it's worth not time, not patient saves. They want to see that it's worth it money-wise. And as Courtney highlighted, these are billable point of care tests, the way a urine is, the way a sugar is. And so that's why this is not phantom scanning. This is saving the images, writing a note, and demonstrating your integration and your plan based on those findings. We took the tack of patient care in our perspective piece, but what we claim and what we feel is we could easily write the business case as well. One thing I want to call out is some people may be working in places with a limited number of ultrasound machines, and that is a reality. I think if you don't work at a place where there are a lot of machines and those machines end up getting used to place peripheral IVs all the time, that can be problematic. But I am not getting paid by any companies, but I will say there are quite a few companies out there that make handhelds. And when Courtney described some of her patient cases, that ultrasound unit came out of her pocket. In other words, it was a handheld. So I believe it could be a cart-based unit because, again, think about the size of an EKG machine, but it could also be a handheld unit. And we know that we have hospitalist colleagues walking around the hospitals using their handheld units. AI was mentioned in that list because it's a little less for us that use ultrasound, that learn ultrasound, that have to graduate emergency medicine residency competent in ultrasound. But the machinery these days have AI features to help for the people that maybe are a little less confident, who want to help get an automated ejection fraction measurement. AI is going to help the people that are POCUS hesitant. And I will say, I know for a fact that many colleagues who are attending are ultrasound hesitant. So I think that's also one of the friction points.
You know, as you were talking about, you know, I guess from a patient-centric point of view and from a ED direct billing point of view, advantages, and it does seem that one of the foci, and Courtney, as in your administrative hat, they'll start with this, is that there's all this pressure of the reason the nurse-driven triage protocols are because there's this pressure to try and have less left welt being seen, less LWATs, less time in the waiting room, certainly less bad cases that happen in the waiting room. And then a lot of consternation, certainly amongst in the emergency medicine physician circles about ordering what gets ordered haphazardly as part of a triage protocol. Like, why is this person automatically getting a chest X-ray or CT scan? And ultimately, when they're assessed, they didn't have an indication for anything. And so it does seem that in terms of how to move the needle, there is an audience of administrators who have this pressure to reduce these metrics, reduce LWATs, reduce time in the waiting room, reduce the cases that for them is less about the patient, maybe about the monetary hit of the event. And so any success or any recommendation of how to enlist non-EM or other hospital administrator personnel to be that support?
Yeah, that's a great question. And I think, when, I try to think of everything when I come up with an innovation or something that we're trying to push forward or move the needle forward, I really try to take multiple perspectives. I think about it from a chair perspective, from a Department of Emergency Medicine, the medical director perspective. I think about it. So I lecture and I tell people I am an ultrasound director that's out there for the community physician. Because ultimately, in my role, we do have an academic hub, but we have many community emergency departments. And the majority of the physicians that I serve as a director of ultrasound are community physicians. And so thinking about the community physician and what does their workflow look like? What does their efficiency look like? How do we build something in that minimizes any types of change so that they can be the most efficient, the most productive, and provide the fastest and the best care for those patients when the environment gets a little bit rough. And so I think when you're approaching some of these leadership and you have a very global view of how something like this could potentially affect not only the business side, but the patient care side and the provider. I'll throw this out there. I feel better as a provider when I make a diagnosis. I feel good about what I do. And I think that helps my own wellness in the longevity of my career. And I want to be in the career for 35 years. And I believe that this is something that helps me. I get excited when I do these types of things. So I really try to think about all of those different aspects when I'm presenting something like this. I think the easy part of this sell, though, is we already do it. You could look at emergency departments across the country. I would love to know if there's anybody on this phone call who doesn't have access to an ultrasound anymore. I consider it standard of care. So it's there. It's just a matter of reframing the way you use it. And the stresses that we all feel, and particularly high up administrators are feeling with patients leaving without being seen, the waiting rooms, busting at the seams. This is a way of mitigating some of those things. As Resa said, I think we have to start talking about it. We've got to start sharing the stories, sharing the data, describing the protocols, what's working, what's not working, to move that needle forward. I think administrators who are willing to listen to these types of innovations and let us start moving those needles are areas where I think we can make the biggest change. Um, the last thing I'll say is, get to the waiting room. It just seems natural that it could fit easily into the triage area. And so I hope that, the people that are listening on this phone call will literally go into their shift tomorrow and grab that ultrasound and see what it feels like to take it into the triage area. because I think people will be surprised at how seamless this can be.
I think one of the things I'm always struck with is sometimes people, particularly people that are learning, are overwhelmed with, oh my God, I can't do all of those ultrasound exams. And they frame it in that way as opposed to, and Peter will know this is my pet peeve, but let's just start with the shortness of breath, which is one of the most common things people present with. Just do lung. I mean, if before I die, I see the final loss of the shortness of breath chest X-ray reflex that exists all across healthcare, we would be so much better off. And candidly, it's such a good rule in, rule out so quickly. That's just not that hard to do. It just isn't. And so maybe one of those best approaches is to start with something and pick one or two and say, just do those because they happen frequently enough that you'll get good at them and you don't have to be overwhelmed by being able to do an ectopic ultrasound in a 350-pound person. I get that's hard. But the other thing as well is where do we start? And I want to frame this in a way it doesn't come across the way, but the shaming or in essence pointing out what is the ratio in your emergency room of the lung ultrasound versus chest X-ray for each of the physicians, and point out who's not doing it, because it's easy to get lost in that. Listen, one of the easiest thing is for a physician to do is just go get a chest X-ray, because you think in your mind, I've done something, it's off my plate, I'll deal with it later. And what we don't think about is that in effect, it actually isn't the most efficient way to take care of that patient, even though it feels that way with just saying, go get a chest X-ray. How much do you guys use those kind of metrics in your physicians in place to say, okay, I've identified those that are a little bit timid, if you will, and I'll be kind, and aren't using it. How do you nudge them along? And do you agree with the idea of starting small and then expanding?
I'll start and share that I've worked in emergency departments where metrics were c- calculated, kept, and shared, and I've worked in emergency departments where they were not. Unfortunately, I believe when metrics are kept, they're actually used to penalize people and to shame people. And I know that's not the intention. The goal would be to use those things to motivate people. But I think that they become scare tactics. And you're spot on. People order the x-ray and order an IV in labs because it's demonstrating that they've done something. And Courtney shared something really important when she was talking about her stories. 10 people come in at once, or a bus load, the city bus unloads a busload of people and everybody checks into the emergency department. There's a lot of pressure on the provider and triage, the physician, provider, and triage. And there is pressure from the team to move things. There's pressure, all the EKGs get handed to you. Um, People may be screaming, people may be in pain. There are a lot of people. Everybody's looking at you. So there's a lot of pressure. And I do think there is this element of doing something or moving to the next because of that pressure, which is unfortunate. I think what you're describing, which is culture change, I have ICU colleague friends that have tried to change the culture of, rather than the daily chest x-ray, the daily portable chest x-ray, no, let's walk around each patient bedside rounds, let's do the ultrasound. The people that are doing that are usually the POCUS experts, but they're trying to change culture. So what you're talking about, and even your original question, is how do we change culture? And I think it often needs to come from leadership. And the question is how to lead your team to adopt this change. Sure, metrics is one option. I think having ED leaders, both operations, residency leaders, and chairs who learned ultrasound, who use ultrasound, who believe in ultrasound, we're not there yet. You know, there's a lot of leaders that have been leaders for decades and they never learned ultrasound. They know it's important, but they didn't learn it. So I think resident doctors, we're talking about academic centers, and not everything is an academic center, but that messaging and leadership has to come from the top. My most successful times as a POCUS section leader came when the chair and the program director were on the same page and messaged the things. It wasn't just the isolated messaging of the POCUS expert. So engaging the leaders, having leaders that truly believe in ultrasound, because I've had both. And when they truly believe, it's game changing for faculty, for patient care. And then I think if metrics are used, to make sure they're not punitive.
Yeah, my experience that Resa's had has been very similar. I do a lot of talks on privileging and credentialing and some work around system-wide ultrasound. And I always start the talk with, how do you get leadership on board? Resa and I always reminisce about this story where we were trying to get a bunch of physicians credentialed. And I jokingly said, when I walk into the department, they would turn and run away from me because they were like, oh, I haven't done my exams. And I said, gosh, after that experience that Resa and I had, I said, gosh, if I ever do this again, I'm never going to do it like this, because this feels terrible. So I think the leadership aspect that Resa mentioned is absolutely key. Going back to reducing the numbers or making things in bite-sized chunks, I think you make a great point, and we've actually implemented this as we've grown our point of care program in the Cleveland Clinic. I have 200 physicians that I oversee with QA, and I QA all these studies throughout the year. And I always tell people, I'm amazed that our community docs choose 1 or 2 exams that augment their practice, and they use them all the time. But if cardiac is the exam that augments their practice, that's what they use. I joke, there's a physician in our system that only does DVT. There's somebody who's really just skin soft tissue or bladder volume, but they're using it for something that they feel helps the patient, is efficient in their workups, and changes their care. And so I think that in this triage area and this triage protocol, bite-sized chunks is absolutely always a nice way to start, where you can say, hey, we're gonna give you this ultrasound to take into triage, and we're just gonna have you do it for this complaint and that complaint. So people don't feel overburdened to learn a new exam, or they're feeling out of their comfort zone. And we've implemented this with like APP training, where we've kept it simple. These studies that we need to do in triage, or that we can do in triage, can be very simple and straightforward. Again, these are not going to be, comprehensive 4 views of the heart, unbuttoning. You're asking a quick clinical question. They can always go back and get a more comprehensive exam, or they can get a definitive study. But the benefit of helping that rule in diagnosis, or helping just create the diagnosis, can be changing for that patient. It can completely change their length of stay. And I think if you give the physicians a couple of examples, a couple of experiences doing that, I think you'll find that, at least in our group, as I started talking about this with our group, I said, gosh, I made this diagnosis and I made this diagnosis. And then one of the other docs was like, well, when I'm in my triage shift, I'm going to take the ultrasound out there too. And then she made a really great diagnosis, and the needle slowly moves forward. So bite-sized chunks is always a good way to go, making things digestible. But that buy-in from leadership is huge.
I was wondering, Courtney, think of metrics this is happening in your shop now, where there's more POCUS triage that's occurring. Is there noise, or are there data points that are coming out that are highlighting the differences when it's being used or not, that are, again, that's a positive data point, is how many times does this change somebody's life, or change patient management, or change time? So I'm curious what type of noise is coming in terms of your experience, where you have a variable group of people who do it or don't.
Yeah, this is new for us, and we've been kind of, in the last couple of months, really innovating and trying to push the needle forward. We have many emergency departments, but we don't have physician and triage at all of them. And so we started looking retrospectively at some of these cases and starting to pull this as a case series. And eventually my goal is to get a lot of data points. But as we start to introduce it, right now, we're really focusing on just getting people comfortable saying, hey, I can take this ultrasound to triage. And then as a director, and this is for, ultrasound leadership on the phone call, I think the really important thing is, how do you make it accessible for them, right? So I know that I can take my cart-based system into triage, and it doesn't bother me, but now I need to think about, how do I make it comfortable for every physician to do that? And in all of your respective sites, for people on this call, it may be a handheld. It may be a finance issue where you need to think about how much can we spend on a machine to be able to bring it out there. Maybe it's an old refurbished machine to put out there for a couple of months to trial it. Um, it's amazing how innovative ultrasound people can be. We will find a way to get a machine somehow, somewhere into the space that we need to. I always think about COVID and how resourceful all of my colleagues across the country were in putting ultrasounds into front rooms when we were worried about infectious protocols, et cetera. So, I think just advocating from the ground up to say, we can do this in our triage area, and going to your leadership and saying, give us the opportunity to try to do this. I think as we message this, as Resa and I really try to get this message out, and we see more large institutions doing it, I think the benefit is everybody can get off this phone call and bring an ultrasound into triage tomorrow. And I think that's where this innovation is really could take hold quickly, because the workflow's there, the billing is there, the order sets are there, the image archiving is all there. The machines are getting smaller, faster, higher sensitivity. AI is there. So all these things are already in place. It's just a matter of spreading the word to the group that's out there. Hey, grab that machine and take it into a different area and do some scanning.
I guess I'd like to take it even further and say, well, let's just assign, and I'll be a homer for a second, a butterfly to triage. You don't have to take it in there. There should be one there.
That's right.
We've got the ability to take a blood pressure. We can just put it there. It'll get used if it's there. Part of the problem for all of us is, and you can say that, if you got to go get something to use it, what do? We
Right.
find a reason not to. And so I think that's one of the biggest things why we advocate at Butterfly, and whether it's at the medical school level, residency, or in practice, put it in your pocket, have it in your hand, get used to doing it. And as Jalen says, it's history, physical, image.
Yeah.
That becomes your standard way to take people. Then you don't have to think about, do I got to go get it? That's the way I practice medicine. And it's just not that big an investment anymore. And it comes back in speed. If you think about it, the average waiting time for a chest x-ray in an emergency room, average, and it's being generous, is an hour.
Wow.
Well, the average time it takes to do a long ultrasound is a minute or two.
Yeah.
That 58 minutes is eternity if you're short of breath and you can't breathe. And it is eternity when patients are stacking up front. So I think the cost and portability of handhelds, Butterfly included, is just to the point where, if you're in an emergency room, buy one, put it in triage. Then you don't have a problem.
Your point about time is actually a very important one. And, Courtney estimated how much time it took for her to do her quick, like lung sliding. Megan Herbst and her group out of UConn Ultrasound did a study that they published, and the average was 7 minutes. And 7 minutes, I think, to a lot of people who are doing a triage shift and trying to move patients through, that sounds like a lot. But if you look, the studies were sometimes more than one study per patient and not in a focused way. I do wonder, there are 50 people, which is amazing. It's so delightful that you joined us for the POCUS Hour. Is there functionality for them to put questions or comments in the chat?
There is.
We'd love to hear what you think. Poke holes, say hooray, I'm doing this tomorrow. We'd love your input and thoughts.
You're on mute, John.
The frog was going crazy now. Now we move from the dog to the frog. At all of your emergencies, how many of you actually see triage in a routine basis outside your institutions? When you talk to people across the country, how common actually is it?
Physician in triage.
Yeah, or physician triage, or physician and ultrasound and triage, Batman and Robin together in the
Yeah.
triage area.
That's the next study or the next question to send across like the listservs.
Yeah, I think that's a great question. I think there's a lot of places that are putting physicians in triage. I think there's probably more ultrasound advocates and experts out there that are in our realm that are probably already doing this. It's just a matter of getting the message out there and starting to figure out, I think physician in triage is something that is much more common than it was 5 or 10 years ago. We're moving our care towards the waiting room. We're getting closer and closer to providing care in the waiting room. And so the idea of where this is happening, who's doing it, is only a matter of data collection. And I think the more the message gets out, the more we're going to start seeing people take an ultrasound out there.
One other question for you, and I'll keep going unless Peter kicks me in the shin. And good thing is he's a long way away, so he can't. We're seeing a lot of ultrasound now on EMS units.
Mhm.
Have you guys seen that as well? And how has that impacted you? And you certainly can step back and say, well, if it can be on a bus, can it be in triage? It seems to make sense. And certainly if the EMTs can do this, Lord knows, is the next step training our triage nurses to be able to do a certain or specific number of ultrasound exams? Where are you seeing that go?
So
Yeah, sorry.
I'll give you historical, and I'll just say that, the functionality of EMS depends on the city and also how long their transit times are. So I've worked in New York City, I've worked in Denver, Colorado, I've worked in Philadelphia, Pennsylvania, and these were the times that emergency medicine and ultrasound were part of the work I was doing. And the shorter times, there was attempts to put ultrasounds on the bus, but they never really came out to much. We were involved at St. Luke's Roosevelt with an EMS study that was coming out of Mount Sinai, and it was really hard to collect the data. I think to your point, John, as the units have gotten smaller, that has changed. I did a course with some of the Miami EMS out of the Gordon Simulation Center at the University of Miami, and they were excited to be able to use ultrasound, but they weren't sure which applications. So, the last few times when I was doing shifts in Philadelphia, I had yet to see ultrasound being brought on those buses unless there was a physician for some reason accompanying or traveling with the patient.
It's
Yeah,
just,
I can.
I think you remember Francis Russell actually published that study in Indiana, which is a pretty compelling one, but that's probably a one-off situation. We're looking to see that expand as more and more emergency departments. I trained Peter came to Annapolis. You think about your own town, and if you go down in your own town, you want your own EMS team to be really well trained.
Yes.
Peter came to town and we trained our EMS people and they're getting there, but I think we still got a ways to go, but it's exciting to see it move that direction.
What about in Cleveland?
Yeah, it's interesting. We ran a study with some paramedics and trying to put ultrasound on some of the rigs. Again, handhelds to get them to do things like peripheral IVs. And we had some mixed success. We did put some ultrasounds on helicopters as well. Um, I think again, the training and the background of that is so important. And then I think Resa brings a really good point about leadership and the fact that so many of the ultrasound leaders are not yet in their career at that point to be positions where they're chairs, vice chairs, heads of EMS. And as we produce more and more residents, more and more trainees that are coming out in ultrasound, I think it's only a matter of time before EMS directors and critical care directors are like, I grew up with an ultrasound and I never practiced without one. I always talk to, I was recently at medical school graduation and I was chatting with another physician. I said, this group that's coming out will never know medicine without an ultrasound, which I just think is so fascinating and so amazing how such an innovative technology has moved the needle so far. So, we all struggle with some of these other environments like EMS and critical care, but I do think as these leaders turn over and they grew up in the world of ultrasound, they will adopt and we will see that this will become even more and more prevalent.
There was one question in the chat.
Yeah, there's a question about, is there a way I can find out about reimbursements as a way to pitch and argue with administrative to have this be part of their practice? This is from Dove Ginsburg.
Thanks for that question. I can just start and say, if you Google ACEP, the American College of Emergency Physicians, and ultrasound reimbursement, they have quite a few documents. The CPT codes get updated yearly, but the basics have not changed. And that pitch that you're putting together is often the pitch that we need to make to prove to hospital leaders that POCUS is important and makes a difference.
Well, this has been, there's a
Here we
question that came
go.
up.
Here we go. The
Right.
floodgates have been opened.
or they were held in, no. Guillermo Izquierdo, extraordinary contribution. Thanks for your motivation. Thanks to the organizers. The POCUS barriers are part of the progress we need to fight together, getting champions and leaders all over. Hear, hear, agree. Wesley, nurse medic educator here. We're trying to push the quick POCUS cardiac 4 view, especially the long axis. Great. For ventricular contraction and pulseless electrical activity arrest. Finding that the long axis is so fast and quick to determine stopping an arrest or transporting works well around the Lucas device. Agree. There's a study, I think, that looks at whether your ultrasound probe is best placed parasternal or subxiphoid. So great. Thoughts on this view for primary cardiac arrest view? Thanks. Oh, I anticipated the question before answering it. So I'll say in my experience with the Lucas, we sometimes found subxiphoid easier to get that 4-chamber view. But I think the feeling has always been, as long as you can get that view of the heart and clip it, meaning record it and show it and have everybody see it and witness it. What's your practice, Courtney?
Yeah, I would agree. Again, I find in those scenarios, you're looking for the view that gets you the diagnostic picture of what you're looking for. And so, yes, with the Lucas, I was always initially taught subxi, but I think I love I always joke the parasternal long and the apical 4 are my 2 favorite views. I love them. When I teach ultrasound, I'm like, I'm going to talk to you about 4 views, but these are the views I love.
Well, I think, and frankly, as you've mentioned, when I'm involved with Lucas, it's either parasternal or apical 4, and probably my go-to has always been an apical 4. But I think to the point of the question, and it's important to get, one is that you're taking a look and get familiar with these 1 or 2 views where for most of the time you can get that clinical yes/no question and make a decision. And they don't have to be pretty, and it's more getting familiar with the comfortable tricks of the trades for those views to get that answer. Um, and we're
There's
out of
another
time.
comment.
Oh,
Oh, sorry. I have 2 more
no.
minutes. I'm going to, Z Chris, I
All
don't want to
right,
leave you out.
let's do it.
Outpatient internal and family medicine see a lot of patients that can benefit from POCUS. We agree. Some will have to go to the ER, some will not based on that study. Hopefully will become like the stethoscope we have with us all the time, maybe even replace the stethoscope. So we agree. And where I worked, the primary care internal medicine physicians had a ultrasound unit, and they were trying to figure out the applications that would help avoid a visit to the emergency department. A big one is DVT studies. That's a big one. And also gallbladder studies. That was my experience. What I'll say is emergency physicians are very, very sensitive about the stethoscope being associated with the point of care ultrasound probe, specifically because we're very careful to make sure we keep ultrasound as separate from and not the same as doing the physical exam, the way the stethoscope is part of the physical exam. And there is an American College of Emergency Physicians policy. If you Google it, you can read the policy specifically stating that ultrasound is not a stethoscope and it's distinct. And it has to do with the fact that not only are we performing it, we are interpreting it, and then we're writing that interpretation and integrating it into our patient care. And to that end, it actually has an assessment and plan, and therefore it's a billable study, which is different than the stethoscope. Those are my 2 cents about just stethoscope and POCUS.
Yeah, I proposed to that. This has been an amazing talk, and I proposed to that as the conversation about taking ultrasound into triage. I think the common reason a stethoscope has been used ubiquitously by practitioners everywhere is that it's there. And to our discussions that if there's an ultrasound in triage, then it gets used because it's there. And so, maybe each of you have a few parting words as we close out. But the theme of taking something which we use, it's part of our routine, it's part of our practice, and bringing it to that earlier assessment data point, partly because we all just have it there and it's a routine to use. So thank you both, and a few parting words would be wonderful.
Yeah, thanks. First of all, thank you guys for having us. Thank you for our audience members who are hopefully super engaged in this conversation and thinking about how they're going to bring ultrasound to triage tomorrow. I think I'm always kind of forward thinking about how can I take my ultrasound to the next spot. And so I just, urge the group that, while we always think some of these things are difficult to achieve, it's really easy to just walk it out there and try it. And you kind of be surprised how quickly and easy you start to be like, wow, I could really integrate this very quickly. So my parting word is give it a shot, take a chance, let us know, contact us and let us know how it goes. And thank you for having us, Resa.
Yeah, I'd like to also thank the Butterfly team. Thank you, community, for joining tonight. Let's keep the conversation going. Reach out. We're all on LinkedIn and tell us how it goes. We want to know your experience.
And I'll end with thank you both very much. And I will also echo the fact that these are two educators who are actually willing to educate, not just in their own institution, but people across the country. So they're very genuine and they're saying reach out to them because they will be supportive, they will be helpful, and their experience here will guide you to not make the mistakes that many of us have made along the way and to learn from their expertise and take advantage of that. And then a final comment is that this will be saved and will posted ultimately on Butterfly's website, so you can share this for people that that wanted to attend and couldn't. Please share it. There was a lot of wisdom passed on from these two that are going to be beneficial, and I look forward to maybe we'll pick a time 6 or 12 months in advance, and then we'll kind of take a pulse and see how far we've gone in that 6 or 12 months to getting this in the triage. And the last thing is, don't hesitate out there to share your stories. Please email us, email them your stories, because it's that one moment, that aha moment that we've all had where we use ultrasound, it made the day, and that really motivates us to continue to do it. And so please share yours when you have it. We've gotten a number of them frequently from people around, and it motivates us and the entire team and the community as a large to continue to advance the skill set. So good night, everyone, and thank you both very, very much for your incredible insights.
Good night.
Thank you.